Thank you. Thank you, Chairman, for the invitation for me to give me the opportunity to present our work here. So I come from Shanghai Jiaotong University. This is my disclosure. So the methodology of computational FFR has been described in this review paper we published in 2020. Basically, you need imaging either from angiogram, OCT, iris, or the combination to create the geometry model. And using some boundary conditions, we can use fluid dynamic solution either by computational fluid dynamic or by fluid dynamic equation. Then you can calculate FFR. So QFR is one of the most widely validated methodology for angiographic-based FFR. This has been validated in many studies, including this 18 study that were published earlier in the leading journal in cardiovascular imaging. So the first study was called Favor Pilot Study, where we try to test that which flow model is better for the calculation of FFR from angiogram. And the study was published in JACC Intervention. We found out that using the contrast flow QFR, we call it CQFR, has better diagnostic accuracy compared to the fixed flow QFR, and was identical, similar to the QFR calculated from the angiogram acquired during hyperemia, meaning that you need to use adenosine to induce hyperemic and the endometric acquisition. We call it AQFR. Later, we performed the Favor 2 China and Favor 2 Europe study. So the Favor 2 China study was published in JACC, demonstrated that when the QFR was using in procedure online during the procedure, as you can see that there was high diagnostic concordance with FFR. The accuracy was 92.7%. Subsequently, we performed the Favor 3 China study, which was published in Lancet end of last year, and the study demonstrated that QFR guided strategy of lesion selection improved 1-year clinical outcome compared with standard angiography guidance. So the event rate was in the angiogram group was 8.8% at 1 year. It was 5.8% in the QFR guided group. Meanwhile, we have been improving the methodology of QFR. So the first generation of the QFR, we did not include the side branch in the reconstruction. So it's only a single vessel. Then you can only assume it's a linear tapering healthy vessel. This will cause some error in the computation. So I mean that especially for bifurcation lesion, you might have a overestimation of lesion severity distal to the bifurcation or underestimation of severity proximal to the bifurcation. So in the second generation, we call it Muller law-based QFR. We reconstruct all the side branch and using the size of the side branch to create this step-down reference diameter. So this is very important to estimate the healthy vessel and include that in the QFR computation. In addition, we made it to work with a single angiographic view. So this will improve the feasibility because in some patients, it might be difficult to obtain a second good angiogram. And we have all the side branch reconstructed in order to assess the QFR at the side branch. So this will be easier for the bifurcation analysis and also improve the accuracy in the main vessel. And using artificial intelligence, we automated the frame counting. So this will improve the efficiency. So the entire analysis time can be reduced to 1 minute. And as you can see in the Favor 2 China study population, we found out that this single view new QFR has a diagnostic accuracy of 93%. So how about the single view compared to the 3D QFR view? The study was just published in Journal of SCAR. So in this study, we compare single view QFR calculated from one of the protocol recommended view. So this is protocol recommended view 1, we call it QFR 1, and the QFR 2. And we use the most sophisticated model to create a 3D, including all the side branch, and we calculate the 3D QFR. As you can see from this case, the number are slightly different. However, all three suggests that the vessel is hemodynamically significant. So these are the main results. As you can see that the single view QFR has almost identical diagnostic accuracy as the 3D mu QFR. So now in China, actually, most hospitals are using the single view QFR because it's simpler. So the evolution of QFR can be summarized with this figure. Actually, before the QFR, we have another development in the lab called FRQCA that was also published in JACC Intervention. This stay in the lab because there's some limitation. The first generation QFR was validated in many studies, and the second generation of QFR has many advantages. So it make analysis time much shorter, and also need only one good view and short learning curve, and you can analyze all type of bifurcation lesion, and you can also analyze the patient with myocardial infarction. And I will come back to analysis of radial wall strength and the microcirculation resistance because RWS and AMR. So the figure look like this. In a single view, you can obtain the mu QFR, and at the same time, if you click if the image quality is good, then you get a radial wall strength to suggest the vulnerability of the lesion behind the lesion, the plaque behind the lesion. Meanwhile, in the computational QFR, we have the angiographic microcirculation resistance called AMR. It was calculated by the distal pressure divided by the flow velocity. So it's similar to the Doppler wear-based microcirculation resistance. So this is one case, the example. The units are different from the IMR, but it's more comparable to the Doppler wear microcirculation resistance. However, in this case, we compare with IMR. The IMR is 20, suggesting is a low resistance. The AMR is 2.04, which is almost 10% of the value of the IMR because the unit is using differently. In this validation paper in 2057 vessel presented EuroPCR, Dr. Fan shows that using IMR as a reference standard, the AMR has a diagnostic accuracy of 87.2%. The radial wall strength also a few study has been presented EuroPCR. So this study was in collaboration with Professor Ge and Li in Zhongshan Hospital, shows that in the group developed non-procedure myocardial infarction AMR group in the subsequent stage had a much higher RWS compared to the control group. As you can see, when the angiographic-based RWS was used to predict non-procedure acute myocardial infarction, the AUC was 0.83. This is another study that in collaboration with Fuwei Hospital in 808 intermediate lesion, the RWS higher than 12% is an independent predictor of lesion progression in 2 years. In the Favor 2, Favor 3 China study population, we also analyzed the non-flow limiting vessel. As you can see, the vessel with higher RWS has significantly higher event load compared to the vessel without with low RWS. So at the same time, we also extend the QFR to CT and then made a CT QFR software called CTA Plus. So this is the methodology from the CT. We constructed the vessel, and we also reconstruct the healthy vessel, and using our own pattern to create the flow, estimate the hyperemic flow, and then using the QFR algorithm to calculate this pressure resolve and the FR. So, and we found out that in this first study published in JACC Imaging, compared to well-based FR, the CT QFR has a diagnostic accuracy of 87.3%, which was significantly higher than the CTA derived quantitative diameter stenosis. And this is another study that's published in JCCT. And this study will compare the CT QFR with single view mu QFR. As you can see, the single-view angiotic-based nu-QFR has slightly higher diagnostic accuracy compared to the CT-QFR. Both are significantly better than the diagnosis. From OCT, we can also calculate the FR. We call it OCT-based FR or OFR, optical flow ratio. This is a software we developed, and the same for IVUS is where it can be quite automatic do the 3D reconstruction of the vessel and the lumen, and using our algorithm to calculate pressure drop and the FR and overlap here. This was first demonstrated in the CIT and TCT meeting in 2019 before the COVID, and the first validation study was presented at EuroPCR in 2019. So in the first study, we demonstrated using FFR as a reference standard, the OFR has diagnostic accuracy of 90%, which was significantly better than the minimal lumen error, and it has higher good reproducibility because automation. In a prospective study that we performed later, that the diagnostic accuracy found at 93%, and there's no systematic bias between the OFR and FFR. And when analyzed by different users, it was reproducible. And also, if you perform the OFR in different OCT pullback with different pullback speed, as you can see, and they were still almost the same. And the same for the UFR. This study was published in Circulation Intervention last year. So using FFR as the reference standard, the UFR has diagnostic accuracy of 92%, significantly better than the minimal lumen area. And when stent was used, we can reconstruct the stent structure and incorporate that in the OFR UFR combination. So these two studies was published showing that after PCI, immediately after PCI, the OFR has a good agreement and collaboration with the wear-based FFR. So the software, in addition to calculate FFR, it can also, at the same time, you can perform the automatic black characterization. So from OCT, as you can see that the software will automatically delineate all the black composition and then showing them in 2D and 3D. And as you can see, in this case, there are a lot of lipid here and also the calcium in white color. So this black characterization algorithm was validated, also published last year in Euro Intervention, and showing that the for basic black composition, including fibrous, lipid, and calcium, the diagnostic accuracy is 92.2%. So this is AI result. This is expert result. So it seems very close. And you can also calculate the plaque burden. Although, for example, in these two cases, you don't see the medial layer. However, the algorithm using consecutive slides and phrenologist can estimate how the EL look like and calculate the plaque burden. And this has been compared to the IVUS at the same location. And the study is still under review, but it shows that there was a good correlation between the OCT plaque burden and IVUS plaque burden at the same location. At the same time, since we can automatically calculate the lipid plaque burden and also the cap thickness, we propose a new vulnerability index called lipid to cap ratio, LCR. The LCR is different from the TACPA. For example, for case B, A, and case B, case A, according to the definition of TACPA, it has TACPA. Case B does not have TACPA. However, clinically, case B has higher risk because it's such a huge lipid plaque burden here compared to plaque A or case A. So the LCR is reflecting this new vulnerability, this information. The higher LCR, the higher risk. The LCR is defined by the lipid plaque burden divided by the cap thickness. So the case B has a higher LCR compared to the case 1. So case B has a higher risk. So we think that this would be a better index to calculate to assess the plaque vulnerability from OCT. And this has been testing in this study that was just published in JACC Asia. As you can see, the LCR has the highest hazard ratio in predicting 2-year mass for the non-covered vessel in ACS patient, significantly higher than the TACPA. TACPA is only 2.7, the LCI is 19, the OFR is 11.5. So combination of the LCI and OFR has the highest hazard ratio in predicting 2-year massive or non-covered vessel. In the same time, we had this paper also published in Euro Intervention, investigating the angiogram-based RWS and OCT direct plaque vulnerability, the LCR. As you can see that using the angiogram-based RWS to predict LCR higher than 0.33, the AUC was 0.86. So this innovation was awarded at EuroPCR this year as the best innovation. We are very happy to receive this award from the Hang Foundation. And finally, I would like to summarize the talk with this slider, showing that the accuracy of different imaging, if you are using FR reference standard to identify hemodynamic single lesion, then this would be the summary of the different technology. And we saw some key publication in this field. And thank you again for your invitation and attention. Thank you.